Hello and good evening. My name is Kevin Malone, and I'm talking to you from Cleveland, Ohio, and I want to welcome you to tonight's session of the Hand Surgery Essentials webinar series brought to you by the AO Trauma North America Hand Education Committee. And tonight's session will be on flexor tendon injuries. Our presenter tonight is Sonu Jain from The Ohio State University in Columbus. I'll be moderating tonight. Becky Nadusky from Elon University in North Carolina will also be presenting a rehab component to this talk for flexor tendon injuries. And Jay Bridgman from the University of Missouri will be helping with answering questions for tonight's session. Here are our disclosures for this series. We believe that we have vetted all of these disclosures and have determined that none of them should have an impact on any of the material presented tonight. As is typical for these sessions, we are going to follow the listed here Zoom etiquette. Your microphones have all been muted and your cameras have been turned off. But on the bottom of the screen, you'll find a Q&A box. And so please, we do want to interact with all of you. And so if you type your questions there, we will do our best to either answer them in a typed written format or actually bring them up for discussion of our faculty here tonight. And here are our objectives for tonight's flexor tendon injury. And I will introduce again, Dr. Sonu Jain from The Ohio State University, who will take over from here. Sonu?
Thanks, Kevin. I appreciate it. So this is a really interesting topic. You could really talk a long time for a lot of different aspects of this, but we're going to try to condense this into an hour of discussion and going over basics as well. So let's start with the history. So Sterling Bunnell, who's essentially the father of modern hand surgery, described this area in the palm called no man's land, which we refer to as zone 2, and I'll go over that later on in the talk. But it was an area in the flexor sheath that he described based upon the terminology that was used between a strip of land that was between the trenches of opposing armies in World War I. And the reason he called this that was because this area failed in terms of flexor tendon repair due to infection, excessive scarring, and flexor contracture. And they really had terrible outcomes. And Boyes actually looked at grafting. So he did primary grafting of this and had great results for this, and he preferred this. And it wasn't until 1967 that Kutz and Kleiner described in their study primary repair of flexor tendons in no man's land to show actually you can get great results here. And this is a turning point in terms of how we addressed flexor tendon injuries. So let's start with some basics, including anatomy. So about the tendon. So the tendon is made of this primary type 1 collagen. And this type 3 collagen encases the endotenon and the epitenon, as you can see here. So you have this collagen fibril, which forms the fiber, which forms a primary, then a secondary, then a tertiary fiber bundle, which then compose the tendon, as you can see here. And so the collagen fibers are bound by this endotenon, and the fascicles of endotenon and fibers are bound by this epitenon to form this tendon. So this is how our structure is formed. And in the hand, we have unique aspect of tendons by having tendon sheets that are associated with them. So tendon nutrition. So how do tendons get nutritional supply? And it's dually supplied by both vascular perfusion as well as synovial diffusion, because it has the tendon sheets. And so it has these unique vincula. So look at this picture on the right here. So this vincula longus superficialis, the brevis superficialis. You have the longus profundus and the brevis profundus. And these are critical for allowing tendons to gain the nutrition and to heal when you have tendon injuries. And so these insert dorsally, so you want to preserve these. And when you have a tendon laceration that you're repairing, you want to preserve these and not transect them, because this is going to be helpful for you in terms of your recovery with your patient. So how does the tendon heal? Well, you have this extrinsic and intrinsic pathway. And extrinsic is exactly like it sounds. It's cells from outside the tendon, fibroblasts, immune cells. The intrinsic is composed of cells from within the tendon. And so you have these three stages, inflammatory, fibroblastic, and remodeling. So days 1 through 7, you have the inflammatory stage and phase. And so that's where you have strength, which is almost entirely from the suture that you placed, as well as the blood clot. And then from day 3 to 14, you start to get an increase in strength, right? The collagen, the type 3 collagen is deposited. And then after day 10, you get remodeling, where the type 1 is replaced by the type 3 is replaced by the type 1. And so this tendon matures over 2 months, but the tendon never achieves full pre-injury strength. So again, going with the anatomy, looking at the FDS, flexor digitorum superficialis. So, you have two heads that compose the origin, the humeral ulnar head and the radial head. So it's from the medial epicondyle, ulnar caudal ligament and coronoid process, and also the anterior border of the radius, where it originates and inserts onto the middle phalanges of your fingers, innervated by the median nerve. And functionally, it's supposed to flex your PIP joint, but it also assists with your MP joint flexion. And these have individual muscle bellies. Of note, 25% of patients can have an absent or an underdeveloped small finger FDS tendon. So looking at the deeper muscle and tendons, which is your profundus, the origin for this is the proximal, medial, anterior ulna, and the interosseous membrane. This these sets of tendons insert onto the finger distal phalangeal bases, and it has dual innervation from both the ulnar nerve for the ulnar tendons and the AIN from the median nerve on the more radial tendons. And this flexes primarily the DIP joint, but also assists with MP joint and PIP joint flexion as well. And this, in contrast to your superficialis, has a Copman muscle belly. And then you have your FPL, your thumb flexor, right? So originates off the anterior radius interosseous membrane, inserts on the base of the thumb distal phalanx. It flexes the IP joint. It's supplied by the anterior interosseous nerve, and it's actually the most radial structure, not just tendon, in the carpal tunnel. So looking at this structure of the FDS tendon, it's this Camper's chiasm, which is a decussation of the FDS split by the FDP. You'll see this in the finger near zone 2. And it actually has two portions, a synovial portion and a membranous portion. This is a great photograph. It shows you this tendinous portion here, and as well as this synovial and membranous portion right here more proximally. So to really understand flexor tendons, you really have to understand the Pulley system. And so the pulleys are these fibrous tissue condensations that form these channels, fibroosseous channels. And so what it does is the pulleys allow your tendons to translate force into rotational movement. And so you have these 5 annular pulleys and 3 cruciate pulleys. And proximal to your A1 pulley, and you'll see this when you do trigger finger releases, you have this palmar aponeurotic pulley, which is proximal to A1. And so your most important and largest pulleys are your A2 and A4, and they insert onto the bone. As you can see from the picture on the right here, you can see the A2 and A4 insert onto the phalanges. And the A1, A3, and A5, these are over the joints. So the A1 is over the MP joint, your A3 is over the PIP, and A5 is over the DIP joint. And these insert over onto the volar plate. And the importance of the A2 and the A4 are in preventing bowstringing. So this is a neat study looking at surface anatomy and how it relates to what's deep. So, when you're making your incisions, this kind of helps guide you to where these pulleys are. So your A2 is more or less over your MP joint flexion crease, and your A4 is kind of where expected to be, the middle portion of your middle phalanx here. So this is neat actually to kind of get a better idea where your structures are, and also where your insertion of your FDP is in relationship to surface landmarks like your flexion creases. So how about the thumb? They also have pulleys too, right? Classically, we thought they had just 3, but we found out they actually have 4. You have a variable annular pulley as well. So this picture on the right shows you your A1, your oblique, and your A2. But you have this variable one, which can be either transverse, it can be oblique, or it can be in continuity with your A1. So the pulleys, as you can imagine, have an important role in terms of the biomechanics of your finger. as we mentioned earlier. So the amount of finger flexion is proportional to the amount of tendon excursion. So if you have pulleys that are ruptured or pulleys that are incised or lacerated, the pulleys, the finger mechanism becomes more inefficient, right? So the maximum tendon excursion is achieved before the full finger, before the finger is fully flexed if you have bowstringing. So this is a neat little way to look at it. So as the moment arm increases from, from the tendon, from the bowstringing, the less degree you're going to get of finger flexion. So this equation sort of gives you that translation. So you're going to have a certain amount of tendon excursion, but as this denominator increases, this is going to decrease. Just physics. So what do you do when you have a flexor tendon injury? Well, like in anything else in hand surgery, you want to get a complete history, right? But you want to know the timing and the mechanism of injury. Was this a sharp laceration? Did it happen yesterday? Did it happen, 2 weeks ago? And then you want to do a complete physical exam, right? Where's the laceration or injury located? Is there a loss of flexor cascade? Is there any adhesions? Is there any stiffness? Do you suspect any pulleys are injured? Is there a contracture? Are the joints supple? Is there a scar formation? Are there nerves involved? I mean, you really want to pay attention. Is there a vascular injury as well? And then depending upon the situation, you can look at whether or not you want to get an x-ray. So you also want to know the zones. And we'll go over this more in detail as we go through the different zones, but just be aware that for the fingers, you have 5 zones. You have zone 1, which is distal to the FDS insertion. You have your zone 2, which is your no man's land, which is from your A1 pulley to your FDS insertion. Zone 3 is from the distal end of the carpal tunnel to the A1 pulley. And then zone 4 is within the carpal tunnel, and zone 5 is proximal to the carpal tunnel, essentially your forearm. And then you have similar zones in your thumb here. So you have the zone T1, which is distal to your IP joint, zone T2 from your A1 pulley to your IP joint, zone 3, which is over your thenar eminence. And then once you get to zone 4 and 5, they're very similar to the fingers, where zone 4 is carpal tunnel and zone 5 is proximal to carpal tunnel in the forearm. So looking at zone 1, very common injury is jersey finger, which is a rupture of the FDP tendon, typically seen with contact sports such as football or rugby. And the ring finger is involved in about 75% of the cases. So we have this Epitenic classification here, which shows the different types of injuries here. And unlike other classification systems, as you go higher on the numbers here, it actually becomes less severe. So the worst type you could have is actually type 1, and that's where you have retraction of your tendon all the way into the palm here, and you have rupture of both your vincula to the profundus. And so, and then you have these other ones, which type 2 is where it gets caught at the PIP joint, and then type 3 where it's caught near the DIP joint by the A4 pulley. And then you have a combination of a bony avulsion here for type 4 with retraction of the tendon proximally off the bone. And you have this type 5, which is a combination of the distal phalanx along with avulsion. So not as common. And the type 4 and the type 5 were not part of the original classification of this. But key thing to be aware of this is that for your type 1, you have to get them to the operating room quickly. You want to fix this within a week. Your type 2 and type 3s, you can, theoretically take up to 6 weeks. Obviously, you don't want to wait that long, but you have more time because the tendon is kept out to length. The blood supply is relatively intact because you don't have both vincula avulsed off. And so what happens is you get contracture of your tendon for the type 1, and also ischemia, and you can't get that tendon out to length. So that's why it's really critical to get the type 1s out to length as soon as possible. And for actual surgical repair of this, historically we use these pull-out button suture technique, where you create interosseous tunnels and suture over the nail plate and try to anchor the distal FDP into the distal phalanx. And there's some other ways to do this as well. Is you can use suture anchors as well. I actually like doing a belt and suspenders where I actually put a suture anchor as well as a pull-out button. So it's kind of a little bit of both. I don't necessarily put two suture anchors like this picture shows, but some people do if you have small micro suture anchors you want to use. But that's what I typically do for this. So, but this is kind of your choice. So zone 1 and 2 injuries. So zone 1, that is not avulsion related, like the jersey finger laceration, you can repair primarily if it's less than 1 centimeter. Sorry, if it's greater than 1 centimeter. If it's less than 1 centimeter, then you have the option of adding a suture anchor or a pull-out button technique similar to what you do for a jersey finger, just because you don't have as much of a stump of a FDP tendon to suture to. And the goal is to prevent hyperextensible DIP joint by doing this. When you have chronic injuries like longer than 6 weeks, they don't do very well. And in those cases, you may want to consider DIP joint fusion. So zone 2, as we said before, is no man's land proximal aspect of the A1 pulley to the FDS insertion. Poor outcomes historically, increased adhesion risk, tight space for 2 tendons. It gets caught under the A2, repairs sometimes rupture due to poor vascularity. And ideally, you want to fix these within 7 to 10 days. And I think just for all flexor tendons, you want to fix the sooner the better, but these ones you really want to attend to. So this is kind of like the evolution of flexor tendon repairs that Jimbo Tang actually described. So it really shows you where we were and where we are now in terms of flexor tendons and conceptual management of injury. So I really want to go over this because this really kind of summarizes a lot of things. So before, we went from a 2-strand repair to multi-strand where we're doing 4 or 6. We thought that the A2 pulley should not be violated, but now we realize we can partially vent it. The A4 pulley shouldn't be violated before, but now we can actually vent the whole thing. We don't need to repair the synovial sheath anymore. We want tension across the repair site. And we also are stressing actually getting adequate bite for the repair, getting about 7 to 10 millimeters into the tendon. That wasn't stressed before. And also the ability to check intraoperatively doing wide awake surgery, which we'll talk about in a bit here as well. And then after surgery, you don't need to start motion immediately. Let the tendons, let the hand have some time to let the edema go down and start your therapy after 4 days. And then the place and hold technique was kind of debunked. It's not useful. It's not found to be useful as much. And actually going to more out of splint motion and active motion has been advocated. And we'll go over that rehab as well later on. So looking at the finger pulleys and the division, so you can vent the A2 and A4 like I mentioned earlier. And so what's interesting is when you vent some of these pulleys, it actually decreases the work of the tendons, which makes sense because not having the friction across the repair. And it was also found in animal models that the tendon strength was up to 60% greater when you actually divided part of the pulleys. Not to say you should divide the entire A2 pulley, but it did allow for increased strength. And with a thumb, you want to be careful. So you have those 3 main pulleys, which is your A1, your oblique, and your A2. I'm not going to go to the variable, but you can divide the A1 or the oblique, but you cannot divide both. But the A2 division does not have any effect. So that's something you want to preserve in terms of the A1 or the oblique. So this is also from Jimbo Tang showing you based upon where your distal aspect of your laceration of your distal stump, if that's where it is, where your distal stump's located, this is where you'd want to vent. So you can see A, B, C, D, where your distal stump laceration is, this is where you want to vent. So you can take the A4 completely, the cruciate, and do that. Similarly, going more proximal, it tells you where you can make your cuts to really get access and do your repairs. And just like I mentioned earlier, you can take all of A4 right here, but you want to take only part of A2. And I think he described taking up to 2/3 of A2. One other thing he also mentioned was trying not to take more than 1.5 or 2 centimeters in continuity of whatever tendon you're taking in the sheath. Sorry, of the tendon sheath. Sorry, not the tendon. Repairs. So meticulous attention to and technique to detail. There are a variety of different ways you can do this. We're not going to go over the different suturing methods. That's beyond the scope of the talk, and largely is based upon personal preference with a lot of people. But ultimately, there are some core concepts you want to take away. One is the core suture provides a majority of the strength of the repair. And like I mentioned earlier, you want to get 7 to 10 millimeter bites on each side. So if you have longer core sutures, you get a stronger core suture. And you want tension. Again, repetition. You want some slight tension at the repair site to minimize gapping. And then also that the strength is proportionate to the number of strands across that site. So more is better, but you want at least 4. But there's also, downside. The more you increase the number of strands, the more suture bulk you're going to get at your repair site. So obviously, you get to a certain point between 4 and 6, and you can't do 10 because you get to a point where that's not really practical. Suture material should be ideally 3 or 4 braided polyester sutures. Failure usually occurs at the knots, and you also want to make your repair slightly bulky at the site. Again, minimize gapping. So this just shows you various types of repairs: Manel sutures, Kessler, Kessler Tajima, oblique, etc. And then this M repair that Jivotang likes using. So again, this is 6 strand. Again, there's even more than these, but just to be aware that there are different techniques to do this. So where should you place your suture knot? There's no consensus. So that different studies have shown different things. Some have shown that it's stronger if you place your knot outside. Some show that it's stronger inside initially, and there's no difference eventually later on. So it just varies. But just be aware that there are different ways to do that, whether or not it should be in or out of the tendon repair site. So another thing to be aware is the suture technique, which is this grasping versus locking. So locking is stronger and it results in less gapping. Well, actually, when the grasping is where you're grabbing and not really locking a piece of tissue into the suture. So this also emphasizes this gap concept we're talking about. So Richard Gelderman in this canine model study that he published in JBJS showed how critical it is to avoid gapping, and gapping in particular greater than 3 millimeters, because what it showed was that when you had the solid line is gapping less than 1 millimeter, and this dashed line is gapping between 1 to 3 millimeters, and this dotted line is gapping more than 3. And what it shows is over a period of 6 weeks, strength progressively increased in those tendons in the model where the gap was less than 3 millimeters. There was no increase in strength during those 6 weeks in the model where you had a gap of greater than 3 millimeters, which shows that weakness there. So this is why you really want to have minimal gapping, because you're not building up strength in that tendon at all. So the other portion of your repair is going to be the epitenic suture, right? You want to have the small caliber suture running around the periphery of your repair site. It does a bunch of things. It prevents gapping. It helps make your bulky repair smaller by tightening up a little bit, improving the gliding, so all the fibers that are herniating out of your repair are smoothed out. It also increases your repair strength. You don't really just place it, even though it's an epitenic suture, you don't place it just in the epitenon. You actually go a little deeper than that. And then also it helps, give you more confidence for early motion. But as we are releasing more pulleys, this is not as important. I still do this even when I do vent or release the pulleys, just for added strength. So this kind of shows you different ways to do this. From my perspective, I just do a running and locking with a 6.0 proline or polypropylene suture for that. And this table just shows you really what you already know. 6 strands is stronger than 4 strands, which is stronger than 2 strands throughout healing. And when you add an epitenic suture, it makes it stronger, up to 20-30% throughout the healing process here, as you can see. So you also want to assess your repair intraoperatively. You want to evaluate this, and what we've been doing now more so is Volar, and I'll go over that in the next slide, And also you can do this digital extension flexion test to evaluate gliding intraoperatively as well. I really like trying to do a lot of my flexor tendon repairs under wide awake local anesthesia, or if they can't tolerate that, with sedation and local, and have them and wake them up and have them do intraoperative motion testing. So Wallant is, if you haven't heard of it, you should make yourself aware of it. Wide awake local anesthesia, no tourniquet, pioneered by Don Lalonde, who's really revolutionized how we've done hand surgery, particularly flexor tendon repair, because we are locally anesthetizing the patient without sedation. We're testing active range of motion prior to skin closure. This has decreased rupture rates because you can visualize the gapping with the motion and you can address this. It decreases tenolysis and adhesions because you're adjusting your pulleys as you're evaluating motion. Make sure that the tendon is actually gliding into the pulley system and not being blocked. And you have more confidence in allowing your patient to perform mid-range active motion early on. And this set of three pictures here shows how Don Lalonde injects the hand and goes from proximal to distal and goes through the already injected site to really infiltrate the lidocaine with epinephrine into the hand. Again, he has a lot of, he's written a lot about this, and you can look that up on his technique on how to do that, including videos. So this is a patient of mine who I did Wallant, and I use this to verify no gapping and verify full excursion of the tendon repair. So you can see here that having a and again, you can see there's no gapping and there's pretty good excursion, and this person did really well after this surgery. So zone 3 injuries, distal to the transverse carpal ligament to the A1 pulley. There's no tendon sheets here. These do pretty well. Sometimes you have to release the A1 pulley to get access for the repair, and sometimes you do have to release the carpal tunnel as well to perform your repair as well. Zone 4 and 5, so zone 4 isn't within the carpal tunnel. It can involve the median or ulnar nerve, and if it does, it's called spaghetti wrist, which is what we would call it also if it happened in the form in zone 5. And you definitely have to release the carpal tunnel and completely. For zone 5, this is our classic spaghetti wrist proximal to the transverse carpal ligament, and goes to the musculotendinous junction of the muscles in the form. And a lot of times it's associated with vascular and or nerve injuries. And these do have better outcomes than zone 2s. And you can be pretty bulky with your repairs because you have plenty of space to do it. And they recommend 4. I almost always do 6 core strands for these because I can, and it gives me more confidence in getting them moving. So we've sort of been taught that, less than 50% cross-sectional area being lacerated, should be observed, and greater than 50% should be repaired. But this is an interesting study, but performed by Kyle Chappell, looking at intrasynovial lacerations, partial lacerations, and obviously if you suspect a partial laceration, you should explore it. And so what he showed was that if you have less than a 90% cross-sectional laceration, if you don't have any triggering, you should just watch it with protected motion. And if you had less than 75% of a laceration, and and you had a triggering component, you could bevel the edges. But if you had greater than 90% laceration or 75% with triggering, then you should repair with a simple epitenic suture. So not the 50% mark, but a little bit higher threshold. Again, just some interesting data that he put forth there. So what about reconstruction? So we talked about primary repair here already. So now we're talking about reconstruction. So the ones that you are not able to do primarily. So these are for failed zone 2 repairs, chronic flexor tendon injuries. Patients have to be compliant with the rehab program, or you shouldn't do it for them. And it's usually contraindicated if they have a fixed flexion contracture, insensate finger, or poorly vascularized digit. Their joints need to be supple to have this work. And it's relative contraindication if they have a functional FDS. So there are some schools of thought that feel that if you have a functional FDS, it may not be worthwhile to do a reconstruction for the FDP just for the friction and the potential adhesions you could have for it. But some people feel that it's perfectly reasonable to do that. And some of the papers show that people who do well are under 21, so avoid it over 21-year-olds potentially. So single stage tendon reconstruction, consider if the flexor sheath is intact, the pulley system's unscarred, you're able to dilate the collapsed pulleys. So this is historically the standard of care that Dr. Boys did until the 1970s. And, as I mentioned earlier, it could be performed with the presence or absence of the FDS tendon. So, the risk I mentioned earlier, if you have the FDS tendon in place, you could risk post-op stiffness secondary to the adhesions. But again, those who are more adamant about fixing this feel that, patients who are who have vocations or avocations that require that DIP joint flexion, such as musicians, should benefit from this. There's one other paper that actually looked at, potentially removing 50% of the FDS tendon to allow more room for the FDP reconstruction. So the two-stage flexor reconstruction, which we tend to see more often here, originally described by Hunter and Salisbury. So stage one, you placed a silicone rod from the fingertip to the forearm or the palm. Usually it was about a 4 millimeter or whatever size you anticipated of your graft. And then stage two, 2 to 3 months later, after the stage one, you'd go in and you'd take your graft, attach it to the rod proximally, and pull it through your pseudo sheath into the distal phalangeal base and attach it there, and then you'd repair to your adjacent FDP tendon in the forearm. So when you're doing this, you have to figure out what kind of graft you want for this. Well, you'll hear terms such as intrasynovial or extrasynovial. So your intrasynovial or your FDS or your toe flexors, and people like these because they have less adhesions theoretically. And the extrasynovials tend to have more adhesions, but they're more readily available, such as the palmaris longus, which we typically use a lot for repairs. But there's no real evidence to support the superiority of one over the other. Peneva-Holledge described a nice technique in 1969 where he was trying to use trying to create intrasynovial tendon graft by looping the cut FDS and FDP tendon proximal stumps together, forming a loop, as you can see here. And then what happened was that you'd come back later, approximately 3 months later or so, and then you'd use that FDS as a pedicled intrasynovial graft and attach it to your distal phalanx. Like you can see this cross-sectional sagittal cut here, how this is repaired at the primary setting, and then 3 months later this is healed, and then you transect your FDS at the usually musculotendinous origin or a little more distal to get enough length to attach it to your distal phalanx, and again attaching it similar to like we talked about for the jersey finger, using a suture anchor or a suture button pull out or both, and whatnot. So this is another picture showing how it's done, looking at it from an anterior view. And Kessler modified this by adding the silicone rod here to create the path for the synovial path for synovial pseudosheath for the path of the eventual FDS tendon. So you also have to be very knowledgeable about the pulley reconstruction if you're going to do a secondary reconstruction, because a lot of times when you're doing a secondary reconstruction for tendon injuries, the pulleys aren't available, right? You have to create those. So you can do primary repair, which is ineffective, so don't even think about it. And there's two types. There's a non-encircling and a loop. So the non-encircling is almost like tying your shoelaces together. You weave tendons or fascia graft to the pulley remnant. Use palmaris longus or your extensor retinaculum for that. And then you can use your loop, which I like doing. I think it's more robust, at least from my perspective. And I usually take palmaris and I wrap it circumferentially around the phalanx. And I usually make 3 loops, and I put a lot of sutures to make it stout and make it tight. And if you're doing it for your A2 reconstruction, your graft is going to be deep to your extensors. If you can do it for your A4, your graft is going to be superficial to your finger extensors. But both have good outcomes. That's ultimately what the literature shows. So before we go into our rehabilitation, I just want to just mention historically immobilization was about 3 weeks prior to the 1970s, and we had a whole slew of different methods to improve post-op rehabilitation, but Duran Hauser with the controlled passive motion, Lister and Kleinert with the immediate passive mobilization, with the splint with active extension and passive flexions, rubber bands, and then early active motion here. And so I was going to show you this patient of mine who is about 3 months post-op, repairing both FDS and FDP repairs, which was not for the faint at heart, and underwent therapy and did actually pretty remarkably well. So you can see here. Pretty functional, and very happy with this result. Okay, now I'm going to turn it over to Dr. Najdusky, who's going to talk about the rehabilitation protocol. Becky?
Hello, everyone. I hope you're doing well this Thursday. So we're going to just do a couple of quick slides on flexor tendon rehabilitation. Next slide, please. So I'm going to ask some questions, and I think these questions are intended to really help us think about the ways we think about what happens after flexor tendon repair or after surgery. So the first question is, are we using common language to describe flexor tendon rehabilitation? As someone who's been in the literature for quite some time, it's always astounding to me how just a small difference in verbiage can really make a big difference in our understanding. Next slide, please. Next slide, please, Dr. Jane. Oh, thank you. Okay, so then language. So our focus should be on flexion. So when we're thinking about language, really thinking about those first 21 days following the flexor tendon repair. So early passive motion are protocols or regimens that include passive flexion of the digits, whereas place and hold is a protocol that includes passive flexion followed by an isometric or a sustained hold. As Dr. Jane said, really this has fallen out of fashion, although I will say 10 years ago, this is really what a lot of people were doing and using. And then finally, true active flexion. These are protocols that include volitional active flexion through any part of the range, including the first third, mid-range, the available range, or full range. And so truly the use of the term early active motion, in my opinion, is kind of a garbage term because it kind of can really be any of these things. So true active flexion is different, in my opinion, than early active motion. Next slide, please. You're going to need 2 clicks because that's going to spin around. So the next 2 questions are, what is the optimal timing for initiation of rehabilitation after flexor tendon repair? And the second question is, how does edema influence initiation of rehabilitation? Next slide, please. So timing, when we think about timing, we often think about the concept of work of flexion, or how hard the tendon or the musculotendinous unit has to work to create flexion. So total active motion was correlated to the latency between trauma and surgery. So thinking about the date of injury to the date of surgery, as well as the date of surgery to the date of initiation of therapy. So the longer time it takes between any of those actual things, so from surgery to therapy or from injury to surgery, the worse the total outcome will be. And so we do want to try to get those patients sooner to surgery and sooner to therapy. The second idea around timing is that there are many, many studies done in the Mayo Clinic and also in Asia looking at gliding resistance and work of flexion as decreased most at day 5, which is the optimal timing for the initiation of therapy. I will say in my many years of practice, we typically started our patients 2 days post-op and had really nice results, but I do think you have to have highly trained therapy to start that early. And then really for edema, the idea of modulate, don't wait. A lot of times therapists will feel very uncomfortable for an edematous digit to really get things started. And so we know that the observation of edema should inform the range of motion, the frequency of motion, and the speed of exercise. So therapists don't have to do full range of motion. They can do partial motion, which was really coined by Raz Evans as short arc motion. So even a partial range we know will produce tendon glide, which is the ultimate, that's our goal in therapy. So we can decide how much range we want to do. We can ask the patients only to do exercises once or twice a day or 3 or 4 times a day. So we can choose how often they do the exercise. And we can make sure they do the exercises slowly and carefully. And that's a really important part about kind of starting therapy, even if they're swelling, but being very careful about doing so. Next slide. So there's a really great study in 2012 that looked at Coban, which is kind of self-adherent wrap, that's just the brand name, and how that impacts work of flexion. And so what they found in this study without wrap is that moderate edema is going to create a 23% increase in work of flexion, whereas severe edema will increase work of flexion by up to 71%. So the edema alone really increases work of flexion, which means the tendon has to work harder to create flexion and is more likely to rupture. Now add the wrap, and that was another significant increase in work of flexion in all the digits. And so now that's just even more work of flexion. And so really paying attention to swelling, modulating the variables you can modulate, and making sure to remove any type of adherent wrap, and even dressings for that matter, prior to exercise, will decrease the work of flexion created by those external pieces. Next slide, please. And so our final question is, what new regimens should I be aware of? So as you're thinking about therapy, certainly the old-fashioned regimens like Duran and Hauser and Kleinert, those are really outdated at this point, and there's much more progressive opportunities for us to achieve much better outcomes after flexor tendon repair. And so next slide, please. I'm going to show you 3 of those that are very current. Fiona Peck in the UK in 2014 published an article about the Manchester short splint. And this is a very progressive idea, certainly, that you would have a splint that was hand-based only, allowing up to 45 degrees of wrist extension. This idea of 45 degrees of wrist extension is aligned with early work in the 1980s around minimal active muscle tendon tension, or the optimal position that decreases the antagonistic pull of the extensors on the action of the flexors. So this is basically a hand-based dorsal blocking splint that allows wrist extension up to 45 degrees. Fiona in this article recommended true active flexion up to the first third of motion, with that motion being initiated at the DIP joint. Next slide, please. And then Dr. Lalonde, with his therapist Amanda Higgins, published the St. John Protocol, which is an open source journal, which is great because anybody on this webinar tonight can get this article completely open source. You can download the whole article without having to have any journal subscription. The St. John Protocol is a static orthosis with the wrist extended. So the patient's in a static wrist extension splint with the MPs flexed to about 30 degrees. This protocol includes a passive motion warm-up. We know that that original Duran's passive protected extension is one of the only early exercises that produces distal glide of the tendon. That's where we get those pesky extensor legs. And so we know that this passive motion warm-up, if we use Duran's passive protected extension, we can get some nice distal glide. This includes true active flexion to the first third to half of motion, with that motion, like in Fiona Peck's exercises, initiated at the DIP to really engage those long flexors. And this protocol actually transitions to that Manchester short splint, I believe, between 2 to 3 weeks. Next slide, please. And then finally, an article came out just a couple months ago this summer from Henry and Howell. And the idea of relative motion has been used with extensor tendons, but this actually obviously flips the script and uses relative motion for flexor tendons. So this is really exploitation of the quadriga effects, and it includes the involved digit metacarpal phalangeal joint in 30 to 40 degrees of flexion relative to the adjacent digits. And so it's a hand-based kind of finger-based, a digital-based MP block splint with a wrist orthosis that's worn for the first 3 weeks. And so if you're familiar with the immediate controlled active motion extensor protocol, this is obviously just the opposite direction. And so this is an exciting new splint and protocol that was just published in the Journal of Hand Therapy this summer. Next slide, please. So what are the new concepts and exercises? And I would say the new concepts in the past 5 to 10 years. First is we're seeing decreased flexion of the MPs in the orthosis to make sure that we're really engaging those long flexors as the patient moves into flexion, true active flexion. We're seeing an avoidance of composite flexion in the early phase of rehabilitation, including the lack of using place and hold, so that's really gone out of style. So active motion in thirds that's been suggested, as well as mid-range true active motion. And then the third point here is increase attention to where motion is initiated. So instead of using those intrinsic muscles, those lumbricals in the interossei, really focusing on the FDP with initiation from the DIP. And then finally, according to Dr. Don Lalonde and Amanda Higgins, trying to avoid full fist place and hold. So with that, I think I'm done with my slides and happy to move on, Dr. Jane, to your next part of the talk.
Thanks. Awesome. That was great. Let's see here. Okay, so just want to go over the complications. So those rupture rates is pretty low, even though we kind of feel this is probably higher, but this is what the data shows. Rupture rate's about 4%, adhesion about the same, reoperation, fall and repair about 6%. So it's interesting. Yeah, Christie showed that the modified Kessler actually has a decreased likelihood of adhesion formation by 134% compared to all the others that which were grouped in the study that he looked at in his meta-analysis of different various kinds of flexor tendon repairs. So, and then the Epitenic Suture also decreased the likelihood of reoperation by 84%. And other complications that you could have include triggering pulley rupture, the quadriga effect, and or lumbrical plus deformities as well from this. And so take-home message from this talk is to be suspicious of flexor tendon injuries and address them early. The repair strength is proportional to the size of the suture and the number of core strands that you're using. And you can assess your tendon repair intraoperatively with active motion by the patient and look out for gapping and make sure that you have excursion into the pulley system. And critically, it's important that you work with your therapist closely for a successful outcome. This is the most critical part after, and probably more so than your surgery itself to really get the result that you need. And so we have a couple of cases here. I'll present this one.
Sonu,
yeah, sorry.
Before we get to the cases, this is Kevin Malone again. I wanted to address some of the questions that have come up. Get your input on to answer some of these questions that have come up from the audience. And then just a couple of comments of mine as well. With your tendon reconstruction, you talked about the standard, Hunter rod technique and then the Paneva-Holovich technique. And one of the key differences here for everyone to be aware of is how the graft gets tensioned. I really like the Paneva-Holovich technique, particularly when we don't need to use one of the tendons to reconstruct the pulleys. But the difference here is there's only one sort of repair site at the second stage, is that, fixing or establishing your tension is a little bit more tricky because you're determining it as you secure that FDS tendon pedicle into the distal phalanx. Whereas with the more traditional two-stage tendon reconstruction, you fix your tendon graft into the distal phalanx and then can establish your tension in the palm or in the distal forearm with your Pulver-Taft weave or side-to-side technique, depending on your preferences there. So there is a little bit of a nuance there, making sure you get the tension right. One of the questions that came up is you spent a lot of your discussion and a lot of the interest, obviously, is on FDP repair. But how about FDS repair, particularly, after the decusation and more importantly, nearer to its insertion onto the middle phalanx? What are your thoughts there?
Yeah, no, that's a good question. So, it depends on what is damaged in the FDS. If I have a complete FDS laceration, I usually repair one slip. I don't ever repair both, and I have to excise a portion of that slip as I repair the other slip. So that way, I decrease that volume. I think what I want to do is I want to make sure my FDP repair is not, it doesn't have a negative effect by the FDS repair. And that's how I address that. If it's a partial laceration of the FDS, and if I have one slip intact, I've just taken out that extra slip just to, again, decrease the volume in that zone 2 area. So that's kind of my, I may change that a little bit slightly depending on the situation, but that's my overall way I sort of address it.
And I think
I was just going to say that's where the active motion test, if you do it under wide awake or light in the sedation and you check them later, those techniques really help me to see what part of the FDS was impeding their motion. And should I remove a slip? Or sometimes, I guess my question to Dr. Jane would be, is there a time in which you would just rather just have a single flexor finger, like it's too bulky, or there's, with trauma and swelling, you would rather just not fix the FDS? Are there any situations where you would do that?
No, absolutely. I would typically do that in the small finger for the most part. I try to, where possible, repair that FDS in the other fingers. In the small, sometimes I will not do that, depending upon, again, just like you talked about, depending upon the excursion of the FTP tendon, depending upon how much tightness there is in that canal.
Some of the concern of leaving the patient with an FTP only finger as I've seen a couple times, either whether after repair where we neglected the FDS or if we were taking the FDS to transfer to do other sort of work, is a hyperextensibility of the PIP joint, which can be a challenging problem to take when you lose that primary flexor motor. So one of the other questions that came up was, we talked about different suture formats, but the actual suture material that you use, Ethibond versus fiber wire, or is there a different preference?
Yeah, for me, I prefer fiber wire. I use 4.0 fiber wire. Sometimes I'll use 3.0 fiber wire. I've been very happy with that. Ethibond, I find it tends to break a lot when I'm trying to tie things down. And I think the fiber wire is just a little bit stronger, so I can be more confident that it's not going to repair as I'm tying it down, or if the failure occurs, it's going to be at the knot and not the suture being broken from within motion.
I think, the suture or the needle that is typically on the fiber wire suture is a little bit more blunt and sometimes harder to pass through the tendon as opposed to the needle that's on the Ethibond. And the fiber wire the knots tend to slip a little bit more. So you need more knots, which is a little bit more bulk at the repair site, which is a study that we did in Seattle when I was a fellow. So my preference is I actually prefer the the Ethibond, but I have been doing some of the M-Tang repairs with the looped 4.0 fiber wire. So with a loop stitch, every pass gets you 2 core strands right there, which just increases your repair for sure.
It's interesting because I've been doing the same.
You guys, can
I
jump in here?
Yep.
So you talked about FDS insertional lacerations, and one of the things I would say is I agree with you in terms of excising one slip of FDS, but if you do that, you have to make sure that you take it all the way back to the A1 past the chiasm, and try to reduce the bulk, as you just said. If you resect the entire FDS, like you said, there's not only a concern of possible hyperextension of the PIP, but as Amit Gupta has pointed out to us, you lose the internal pulley within the flexor sheath because the FDS acts as a pulley for the FDP to hold it down. So you have to caution the patient that they may actually have a little bit of bowstringing and not composite flexion if you leave them with one tendon finger. Something to think about.
Good points for sure. Jay, did you have other questions from the participants that you wanted to bring up?
One question that came up just now is when you're thinking about, for example, between a index finger or a small finger, caliber of the tendon is smaller. How do you kind of address your estimation of the suture size, Dr. Jain?
Yeah, I try not to go smaller than a 4.0 in the finger. I haven't had to use something smaller than that, so I've been able to get by with that. I haven't had the reason to use a 5.0 at all. So 4 is probably the smallest I'd do, and I think the data supports that. I think if I do something small, I'm not going to get the strength that I need across the repair site.
Jay, any more questions, or you want to go on to our cases?
I think the last question would be, is there any alternatives to silicone rods for a 2-stage reconstruction? I thought that was a great question. I don't know of any, but I was going to ask you guys if you thought of any. I know that they're very expensive. That's one thing to remember, is that each silicone rod, depending on your hospital contracts, but they can be very expensive.
So maybe I can answer that, having worked in resource-poor environments in my past life. Any intravenous tubing of a suitable size can work as a stopgap. It is not ideal, but then again, you're dealing with a non-ideal situation anyway to begin with. And all you're doing is leaving it there as a foreign body to create a response of a sheath. And it works reasonably well. I would probably, if you push came to shove, you can also use red rubber catheters, but they excite more of an inflammatory response. So, intravenous tubing is much better option, and it slides in and out easily, and it creates a nice sheath. But that's just a backup plan in case you don't have silicone rods.
Yeah, the IV tubing would be quite smaller than I imagine your anticipated tendon graft. at your
Right.
second stage.
Therein lies the key. It comes in different. It doesn't come in different sizes, but if you were to use palmaris longus as your graft, more often than not, it'll be okay.
Kevin, it's Chuck. Can I make a couple of points?
Of course, Chuck.
Thanks. Great talk. One is the looped sutures in terms of, does it count as a double strand if it passes through the same tendon path as a single strand twice? And I would say my take on that is it's a larger caliber suture rather than another strand. So I'm not really sure that a double-stranded suture counts as two strands. It's controversial. The second is, it'd be nice if we knew more about our patients before we operate on them. Usually we don't. And the protocols, including what Becky showed with the wrist unlimited motion or slightly limited motion, certainly allow for more use of the hand. And anything short of a 6-strand repair is not strong enough to allow for use of the hand or use of the finger. It permits motion of the finger, but not use of the finger. And so just to keep that in mind, if you don't trust your patient, I'd be more inclined to tie them up and deal with the flexor tendon adherence rather than a rupture.
Excellent point. Meeting these patients in the emergency room or in the pre-op holding area is hard to get a sense of who they are and who they're going to be during the rehab program. And I'm sure Becky would have some excellent stories there as well.
You can do that in the second stage or delayed reconstruction. You can send people for therapy to see if they'll follow a pre-op therapy program. Mainly, you're trying to get passive motion. And then if they don't show up to any of those appointments, then you realize this person should not have a 2-stage reconstruction.
Absolutely.
I will say, I worked in St. Louis in a multi-trauma center, and I'm always curious about our willingness to maybe not think our patients are capable of following our instructions. And so we had a lot of really good results with people who other people might have said, oh, there's no way they can do that protocol. So I would never prejudge my patient. I would really give them a shot to see what they could do and start small, knowing that even a little bit of motion is going to produce a better outcome than locking them down altogether.
Well, in Boston, we have this coffee called Dunkin' Donuts. And we tell our patients, don't use your hand. And they say, of course I'm not using my hand. And they come in with a Dunkin' Donuts cup of coffee. And when they get up to walk to therapy, they grab the Dunkin' Donuts cup with their surgical hand. But they don't think they're using their hand.
That's called differential glide, Chuckles. They're just doing what Becky told them to do. They're using differential glide.
Chai, do you think we have a few minutes to go over a couple cases?
I think so. The only you should go over a couple cases, definitely. But Sonu, I have a little bit of a question for you in terms of, you made a remark about Valant and said that it reduces rupture rates and tenolysis, et cetera, et cetera. And I think I would just use that remark with a little bit of a grain of salt, because reduction in rupture rates and tenolysis, because you use a technique, can be said to be correct if you have a prospective randomized trial which compares that technique with another technique and shows it to be superior. Otherwise, it is one person's experience which is being propagated. And I think we have to be careful because our audience may take it the wrong way.
No, very good point. I think I should have said the thought is that it reduces, rupture rates. Yeah, that you're correct.
More of a fait accompli than a possibility. And the fait accompli is not what I'm sure you intended.
Okay, so now let's go through, I think you have a case and then there's one, I have a case too. So we'll go through those and wrap it up.
Yeah, this is a 22-year-old female sustained knife injury to the volar hand, small ring finger, has some numbness, loss of motion. So I think this is actually a great picture to look at because you know a lot about this patient without even examining the patient. Just look at this cascade. You can see in the small finger, there's no flexion. So there's likely both your FDS and FDP out, right? in the ring finger, it looks like the FDS is, intact partially or completely, but the FDP is out. Just look at the cascade, because you don't have the flexion across both flexion creases at the PIP and DIP joints. This is a great photo just to really get a concept. So went to the operating room, and she had a complete laceration, zone 2, FDP, FDS, small finger, and complete FDP, ring finger, and partial of the FDS in the ring finger. So the ulnar slip was completely lacerated. The radial slip was intact. You can actually kind of see that right here. And so let's see, she had an ulnar digital nerve of her small finger that was lacerated, which I repaired. So not relevant necessarily to the talk, but I guess thoughts of the faculty. I know we discussed this already with our discussion earlier about how we address, FDP and FDS laceration. So I addressed this just like I discussed earlier. I did repair the radial slip of the FDS of the small finger here, and I did take the ulnar slip completely, pulled on it pretty hard, and excised a good portion of it under the A2 to remove that bulkiness. And so one of the techniques that we do not talk about, but that I do for this is I'll take a hypodermic needle and kind of help hold the tendon out to length. So when I'm doing my repair, so it's a nice little technique. So I know many people do this, but in case you haven't done flexor tendon repairs before, this is a nice way to kind of keep your tendon out to length when you're going to do your repair. So this is our FDP we're looking at. And this is the repair after everything's all said and done. So we got that cascade back and looks pretty appropriate for what I'd expect. And this is intraoperative. Again, I had this patient. She was not a pure Wallant. I had to do a little sedation. I don't think she was somebody who'd be able to tolerate wide awake, but woke her up and had her worked on flexion intraoperatively to really gauge and make sure that, number one, my tendons were gliding, and number two, check my repairs after the set of extension and flexion to make sure I wasn't gapping. Okay. Any questions or comments about that?
It's a nice, elegant case for sure.
A4 is left behind, or did you get rid of it altogether?
Oh, sorry.
Did you get rid of the entire A4?
Yes, I had to, because the repairs for both of these were essentially under A4.
Yeah, yeah. No, I mean, I love your approaches. They're very nice. And in case I don't mention it later, you and Kevin and Jay are to be congratulated for doing such a nice job. Fantastically done.
Thanks.
Thanks, Jai. So we can finish.
I was just going to say quickly, I find that the video is helpful to instruct the patient, because even in the post-op area before they leave for the day of surgery, we can show them this is the motion that we got. And so that can be encouraging to them as well as the therapist.
Yeah.
Jane, quick question.
Sorry, I forgot one more thing. Becky, awesome job. we need that. We need that from you. Thank you.
Dr. Jane, quick question for you. How many strands are crossing the repair sites of these tendons?
So I did a 4-core strand repair, and I did an epitenic suture with a 6-0 polypropylene stitch.
Yeah, and the one thing, I think the point that I think is really important for the surgeons that are on this webinar tonight is that your therapists need to know that. Your therapists need to know how many strands are crossing the repair site. That has really important implications for the exercises that are safe and that they can choose. And as Dr. Cassidy said, we're not going to start with having them functionally use the hand, but we certainly do want to start with safe exercises. And so we know with the 4-strand repair, there are things we can start by doing. And so that's essential information that your therapist needs to know.
Hey, Sonu and company, before you go, since you talked so much about Volant, would you like to spend a minute educating our audience about what you do when you mean Volant, and how do you use it, what substance you use, how much you inject, just a little detail other than the pictures you showed?
Yeah, so what I use a combination of about 4 cc's to 1 cc of lidocaine with epinephrine with sodium bicarb. So, so for every 10 cc's of local, 8 cc's is the actual anesthetic, and and 2 is the bicarb. You can decrease that a little bit if you want to, but I think that helps with the burn from the injection. And so what I talked about earlier with that one picture, whatever structure I'm trying to inject, I inject proximal, and I inject slowly, not fast, and I try to inject perpendicularly to the skin. And once I get that local anesthetic infiltrated, then I'll go through that site distally where I'm already numb and inject further. So that way the patient's not feeling each subsequent injection. And then I'll infiltrate it until I get it a kind of like a field block in the area, because you're trying to not only get local anesthesia, you're also trying to also get the what's it called, the decreasing the blood supply, or decreasing the blood flow into the area with the epinephrine, creating a more of a hemostatic space for your surgery. So, and what I also do is give myself at least 25 minutes after injection to let the local epinephrine take effect to get that vasoconstrictive state.
Great, thanks.
So let's go to the next case, Sono, if you wouldn't mind. So this is a case that I submitted, and this is a 58-year-old female, and given us all the bird, and as many patients have many of us have seen patients who want to give us the bird. She had an injury to her dominant hand, and this is what she looked like at surgery, but the history is a little bit different. So go to the next slide. She fell and had a proximal phalanx fracture at the base. Came to the emergency department, where the fracture was identified on X-ray. Go to the next slide. This is her post-reduction X-ray, really not really much of a reduction, where the ER staff just puts her into a splint. And then go to the next slide. Here she shows up 1 month later for her first follow-up from emergency department. Fracture is still displaced. She doesn't have much pain, and she is pretty much against considering a surgery. She has some pretty significant medical issues as well, despite her relatively young age. So at this point, we sent her to therapy and let her start working on range of motion, letting her know she was going to likely have a deformity, the pseudobutynear deformity commonly associated with this fracture alignment. So go to the next slide. So we started her on range of motion at week 4, and at week 5, she felt a pop and was now unable to move her finger. So at this point, she was unhappy that she was permanently given the middle finger to everyone, and now she was ready to consider something. So next slide. And this is, essentially what her hand looks like when she comes back after that pop. Next slide. So, this is a diagnosis for here was, she had a flexor tendon rupture, likely underneath the A2 pulley, right where the fracture occurred. And options for her were made challenging. You can go ahead and click the next button because, she has severe pulmonary fibrosis. Pulmonologist said not suitable for general anesthesia. Anesthesiologist not all that keen on doing anything for her. And so there was significant desire to do this as one stage under regional anesthesia only. And so go on to the next slide. Here's her intraoperative findings, and you can see the ruptured FTP and FDS tendon underneath the scarred A2 pulley. Next slide. And so we did a single staged active Hunter rod. And so the active Hunter rod has that loop proximally where we can take her FTP tendon and pass it through the loop and secure it to itself after we've established the tension. And then it's secured distally into the distal phalanx with a screw through a washer that's built into the Hunter rod. And we thought, we'll see how this works and how long it lasts and let her go with that. And if it fails, which it could, then we'll have to figure out what she wants to do next. Next slide. This is her after closure. Next one. And here she is at 2 months, the last time she followed up. So still has a pseudobutynear deformity because we didn't do anything with the fracture deformity, but she can make a full fist. And she was happy, and so was I. So that's a good outcome. Okay. Any other comments from our panelists, questions from our participants, Jay?
No, we're all caught with the questions. We're all done.
Excellent. Well, Sonu, great job. I think there's a couple of closing slides. So don't forget the remaining courses on our protocol here through next couple of weeks. And then we'll take a break in mid-November. After the new year, a lot of the more standard conventional webinars that are put on specific topics will resume. So stay tuned and follow your AO, or make sure you read the emails and distributions from the AO North America regarding further educational opportunities even after these end. This has been recorded and will be available on the AO North America YouTube channel. And so if you want to go back and watch part of it, you certainly will have the ability to do so. And thanks very much for all of your participation here tonight. Remember to stay on for the questionnaire, which will then give you access to claim your CME credits. Thanks, everybody. Have a good night.